Now, this particular patient came to me right when Dr. Rajshekhar was talking to me about this talk, and this is what inspired me to choose this topic for today. Now, what you see there is, what do you see there? Yeah, there is clinically missing 1-1 and 1-2. Now, what has happened to the patient very sadly is, the patient has got a fall, he has wrapped his tooth in a newspaper and he has taken to the dentist. The duration was around 2 hours or something. So, the clinician or the doctor, dentist, did not put back the tooth. Okay, so the patient did not put back the tooth, he has given rest, all the things were done accurately. He was given a tetanus shot, the patient was reassured, the patient was referred back to us after 2 days. Now, this is the condition of the patient who is coming back to us after 2 days with no tooth in hand. Now, what is your idea about this? What do you think is the situation of this patient now? He doesn't have a teeth, right? Do you feel comfortable in telling your patient who is 11-year-old that you're not going to have a maxillary central incisor and maxillary lateral incisor, of course, for the rest of your life? Are you going to be happy about that? No, it's a growing child, okay? It's not an adult, it's a growing child, which means they are in the period of schooling. They have got a lot of psychological trauma. Yes, the psychological trauma in children is real, especially when it comes to appearance. All the children invariably, they are subjected to some amount of emotional trauma when their, appearance of the teeth and face does not, sit along with the others. So this child is going to have, a psychological trauma because there is no teeth. There is going to be speech disturbances. Do you agree with me or not? The child has to be with an RPD. The child cannot have any kind of fixed prosthesis until the child completes his growth. So the child is going to be with an RPD until he is 18 years of age, that is 7 years of life. And he has to keep changing his RPD because your palate is going to keep growing. Now, all this could have been avoided if the dentist chose to put back the teeth. Now, can you blame the dentist? Yes or no? Now, the patient has taken the tooth in a dry state after 1 hour. So the dentist did not put back the tooth. Now, is the dentist to blame here? This is what you read in our textbooks, right? If the extraoral dry time is more than 60 minutes, the prognosis is bad. So I'm not going into the basics here because I find this is an elite crowd, so I'm just taking only the advanced things, okay? So extraoral time more than 60 minutes and it's brought in a dry state. So the prognosis is bad. So the dentist has actually taken a good call according to him, right? But what is missing here? The missing point is the dentist was not aware of the recent guidelines, right? Now whose fault is this? Is it the dentist's fault? No. The guidelines are there in paper. Now who is supposed to take it to the concerned stakeholders? Who is supposed to take the responsibility of informing the public? Now that is where we come in, okay? So, to just, substantiate what I said today, this is a study which is done in India. So this is basically evaluating the knowledge of dentists regarding emergency management in children. And of course, you could predict the result of the study, right? So which calls for action that all the dentists, invariably of whatever specialty they belong to, should have a knowledge of pediatric dental trauma because you are dealing with a child, a very growing child. Now this study that is regarding permanent tooth injuries. Now let's come to a much sensitive topic, primary tooth injuries. Now this is a much grayer area, I would say, because a lot of dentists do not attempt to treat anyone, who is 3-year-old, 4-year-old, they do not attempt. So this particular study was done in Savita Dental College where they evaluated the knowledge of dentists to treat primary tooth injuries. Of course, I am not getting into the result of the study, which is well spoken of. Now with all this said, now this is why I am here. So what's the goal of my talk today is, okay, I'm not going to get into the basics. Maybe I would give you some, technological advancements, I would give you some hints and I would brush up on all this. But my basic aim and goal today is to provide information for the immediate and urgent care of traumatic dental injuries because traumatic dental injuries are much more common in the rural areas than in the urban areas, and every street has got a dentist practicing there. So information for immediate management of traumatic dental care is vital. Now, I'm not going to get into the process of diagnosis. I feel all of you know how to diagnose a traumatic dental injury, how to do a radiographic examination. But I would like to stress one particular point here when you're doing a clinical examination. Of course, you know how to do a clinical examination, proper light, and do not miss out on anything. But there is something which always gets missed, which we find during our clinical examination, is missing out on concomitant injuries. Now, I would like to explain on this. Let's say the patient comes to you with just an enamel and dentine fracture, or let's say just an enamel fracture. There is no urge. The patient is not going to give you a severe symptom, pain, nothing. Just a fall, there is no severe bleeding or anything. The patient is going to come to you with just a complaint of enamel fracture. You're going to look at it just through your eyes and you're going to give a diagnosis of enamel fracture. Now, there can be some other existing injury which you might have missed. For example, a mild subluxation, which the patient might not have noticed. There would not have been no severe bleeding from the periodontal ligament. Or a root fracture, which the patient would not have any symptoms at all. Now, what happens is, whenever there is a concomitant injury, that is, whenever there is another injury, the risk of pulpal necrosis is higher. Now, is there a risk of pulpal necrosis in an enamel and dentine fracture? Does pulp get necrosed in an enamel and dentine fracture or just an enamel fracture? No, right? No, that's only enamel, dentine, your pulp is fine there. But let's say there is a subluxation injury which you have not noticed. Let's say there is a root fracture that you have not noticed. Now, what happens to the pulp? Definitely, within 4 weeks, your pulp is going to go in for the dump. Okay? So, always look for the concomitant injuries. Now, radiographic examination. Now, all of us do take radiographs. I believe that whenever there is a traumatic injury, we do have the habit of taking radiographs. But this is the recommended, guidelines for taking radiographs when it comes to traumatic injuries. Now, this is not a hard and fast rule. This can be changed depending upon the age of the patient, depending upon the financial status of the patient, depending upon the cooperativeness of the patient. You can change this. But this is the ideal survey of radiographs for traumatic dental injury. So you should have a parallel radiograph between your maxillary central incisor, between your lateral incisor, an occlusal radiograph, and of course on the lower central incisor also. Now this is something which all of us miss and extremely vital. Photographic documentation. How many of us do that in our clinic? Not many, right? Especially when it is an enamel fracture, whenever it is a dentine fracture, we do not go into the details of, recording it photographically. But it's very important because for soft tissue healing, for monitoring any small amount of tooth discoloration, that's a giving sign for, pulpal necrosis, right? The re-eruption of an intruded tooth, development of infrapositioning of an ankylosed tooth. So all this can be easily diagnosed by taking just clinical photographs, okay? Now comes the very important point, sensibility testing and vitality testing. Can you tell me what is the difference between both? What are we regularly doing in our clinic? Sensibility testing. Sir said vitality testing. How many of you go with sensibility testing? How many of you go with vitality testing? Okay, what we normally do, that is with gataparcha, the hot gataparcha, you heat the gataparcha, you place it on the tooth, that is your sensibility testing. That is not your vitality testing. What are you testing there? You are testing the neural activity, the nerve activity. But vitality is when you check the blood flow of the tooth. Okay, so you have to keep that in mind. Whenever you say that, okay, the pulp has become necrosed, no, it has not really become necrosed. I want you to have this in mind because by the end of the lecture, this is going to help you to form a diagnosis, okay? So whatever we are doing right now, heating a gataparcha and keeping there is not necessarily checking the pulp's vitality. It is just checking the neural conductivity of the tooth. Now let me come to this neural conductivity. Whenever there is an injury, a neural conductivity is harmed in that area. Does nerves regenerate? Yes, nerves has got the highest potential to regenerate. So always bear that in mind. Whenever you do a sensibility testing and you declare a tooth to be non-vital and you go ahead with doing all the RCT endodontic procedure which might not have been essential for that tooth. So keep in mind what we are checking is a neural conductivity of that tooth which can even be restored. But ideally we should be testing vitality of the tooth. Now vitality is, you can check only the blood flow, you can check by pulse oximeter or laser Doppler flow meter. Now pulse oximeter, all of you must have seen how bulky it is. Can you place it on the tooth? No, what we use in our fingers, can you place it on the tooth? No. So you need specialized sensors for that. So right now, that's why we do not use all these in our regular clinic. But that is fine, that is fine. When you're using your hot and cold testing is fine, but we have to keep in mind that that is not the end deciding point. Now again, let me come back to that sensibility testing. Now A delta fibers, the innovation is very less when it comes to young immature tooth, right? So in a young immature tooth and in a primary tooth, whatever sensibility testing you are doing might not be accurate. So resort to some other method. Always balance it with your clinical findings. Always balance it with your history. Right? Are we clear on this? So can I go forward? Okay, now all this, I think all of you must be extremely well aware of this. Uncomplicated. Now I have divided my topic into two: permanent tooth injuries and primary tooth injuries. Okay, permanent tooth injuries, first we will be talking about uncomplicated crown fracture. What is uncomplicated? We do not have a pulp exposure there. Okay, uncomplicated. It is fine. It's fine. It's not going to complicate your life or the patient's life. So uncomplicated crown fracture is enamel and dentin fracture. So first you have enamel fracture. Enamel, you have enamel infraction. Now this is something which we always oversee. Fine cracks in the enamel. Now this fine cracks may someday lead to sensitivity and dentin loss. So just check it, fill it. Next you have enamel loss. Now enamel loss, yes, if there is an enamel fracture, if you can rebond the fragment, do it. Otherwise go ahead with an aesthetic restoration. Now enamel and dentin fracture, again the same methodology. If you could find the fragment, rebond it. Otherwise go ahead with an aesthetic restoration. Now what is that? Oh, I have given the heading. What is that? What fracture is that? Yeah, enamel and dentin fracture, right? Both enamel and dentin fracture. Now this is what you see clinically. Now see the radiographic picture. Can you see root fracture there? Completely unassuming picture, no bleeding, nothing, but that's all the patient presented with. So do not go by what you see through the naked eye. Look beyond what you see. Okay? Now I'm coming to complicated crown fracture. See, I'm just brushing on this because I just want you all to know the reason guidelines. Okay? Now complicated crown fracture is the primary goal. What is complicated? The pulp is exposed. So the primary goal in complicated crown fracture is to preserve the vitality of the tooth. So what do? When you have to preserve the vitality? So you have to preserve whatever pulp is remaining. Let's say the patient is coming to you after 3 days, 4 days, a week. But still, if the patient is not giving you any symptoms of non-vitality, if you do not find any great changes radiographically, forget what the sensitivity test is saying, because I told you it's not that reliable, right? Even if the sensitivity test is going to tell you negative, do not jump into RCT. Do not jump into removal of pulp. But remember, give the tooth a chance to heal. The pulp is an extremely innovated and it's a miracle tissue there. It has got great capacity for healing. That's the current thing. So give it a chance to heal. Okay. So remove only the pulp that is infected. That is, do a partial pulpotomy or a cervical pulpotomy. Preserve the pulp that has not been infected. Okay. So that is the goal of complicated crown fracture. Now let's say you have a crown that is completely crushed. You need to give a restoration. So any kind of endodontic procedure, you have to give a post-endo restoration, right? So if you cannot have a crown, there is no point in maintaining the pulp, right? So in that situation, when you cannot give a superficial restoration, then go ahead with an endodontic treatment, give a post, and then go for a crown. Only in that situation, okay? So this is basically a complicated crown fracture. You can see, right, pulp is exposed. Can you make out the pulp being exposed there? This is the radiograph. You can find that the apex is open. Right? Can you appreciate that the apex is not completely formed? So this would be the situation of majority of the pediatric patients, because when does the root get matured? After 3 years of erupting into the oral cavity, right? More or less. So this would be the situation of most of the pediatric patients. So this particular situation is very favorable, because why? When an apex is open, what is there? In the apex you have stem cells. Okay, stem cells are like miracle cells, right? Our oral cavity has got stem cells. Almost, most of the niches are there in oral cavity. So whenever there is an open apex, consider that you are fortunate, consider that the child is fortunate, regardless of the injury. So what we decided was, even though the patient reported to us, after a few days, we decided to go with a partial pulpotomy. Now that is what you see. We open the axis, we just remove the coronal pulp, and we place something called biodenting. Now, all of you must be familiar with this name, I guess, biodenting. So what is biodenting? Yeah, it's a bioceramic. So initially, way back, we were using calcium hydroxide, right? From 1960s, calcium hydroxide have been regularly used for any pulp capping, for indirect pulp capping, for lining. We use calcium hydroxide, right, left center calcium hydroxide. But right now, we are not favoring calcium hydroxide much. It has got its own disadvantages, and of course, the technology is growing. When the material is growing, material side technology is growing, we just take it in. So now it's the era of bioceramics. So now we have MTA, we have bioceramics. So I would request all of you to try that. If in case you are using calcium hydroxide, kindly shift to the available bioceramics, like biodentine or MTA might be a bit tad costly. So maybe biodentine is a good alternative. Now that will give you very good results. Now see, this is how the tooth, this is how the root is. We have placed biodentine, and this is what the patient, when the patient came back with a fractured restoration, till then the patient did not report to us. Now that is the completed root of the patient. Can you see the root lengthening? Now root length, whenever you use calcium hydroxide, what happens is you get a stunted root growth. You do not have thickening of the root. Now both these roots, the thickening, the radicular dentate thickness and the height is almost similar to that of the lateral incisor. So this happened because you used the potential of the remaining pulp. You used the potential of the bioceramics. So I would again like to insist saying that whenever, if at all, you could preserve the vitality of the pulp, go ahead and do it. Do not jump into removing the pulp tissue. Now next comes the very important stuff. Okay, fine, the pulp is vital. I am going ahead with pulpotomy. What if the pulp is non-vital? What if, now the previous case the root was open, but the pulp was vital. So I went ahead with pulpotomy. Now let's say a situation, the patient is coming to you after 1 year of trauma. That was not actually a class 3 trauma, but a class 2 trauma. The patient is coming to you after 1 year. The tooth is all black in color. By seeing, you understood it's a non-vital tooth. The apex is open. The patient did not have any symptoms at all. Only recently the patient has got some pain and some swelling and all that. So the patient is coming to you. Now how will you deal with this situation? It's an open apex. It's a non-vital tooth. What would you do? If it's a closed apex, we can happily go with RCT treatment, right? You can do an RCT, you can give a post and core or just a crown. But that is an immature, there is no apex there. So what would you do? You would want to form an apex. Right? You would want to form an apical stop. Now this process was initially called as, what is that? Apexification, which we all read in our textbooks, right? Apexification, 1960, Hermann first, whenever he introduced calcium hydroxide, that was his goal, to create an apical stop. So that whenever you put your GP inside, it is not going to get extruded. You want a 3-dimensional covering for your root canal endodontic material. So that is called apexification. Now the disadvantage of apexification is there is only an apical stop there. There is no root lengthening. There is no root thickening. So what happens is the study has found that all these apexification tools, they undergo fracture very easily. Because once you put calcium in that, calcium is supposed to attract all the calcium ions from the blood. But sometimes what happens is even from the tooth it gets leached out. So they stopped calcium hydroxide. So then came bioceramics, MTA, biodentine and all that. So that was called one-step apexification, where they create an apical barrier. Have you heard of it? Apical barrier where 4 to 5 mm of bioceramic material is placed, and then you place all these, you place gutta-percha and finish the tooth. Now again, people are not quite happy with that. Why? Because technology is growing. I am a dentist, I should give back what is lost to the patient. What did the patient lose there? The patient lost pulp, the patient lost denting. So as a dentist, I am entitled to give back. Right? So that is when this process is coming, regenerative endodontics. Heard of it? Heard of it? Regenerative endodontics. How many of you practice regenerative endodontics? Any of you? No. It's like the new age cinema, right? Even Rajinikanth and Kamal Hassan has to work with Lokesh Kanagaraj, right? So I feel all of you should have a taste of what regenerative endodontics is. So regenerative endodontics is nothing but you exploit the stem cells. Where are the stem cells? In the apex. In the apex, you have got a wonderful population of stem cells there sitting idle. They have no job to do. But they are undifferentiated mesenchymal stem cells, which is quite similar to your umbilical cord stem cells, right? Which you bank, which people market. But you have got it simply sitting in the apex of your tooth. So scientists thought, why not exploit it? So now you have techniques where you use these stem cells to create the apical barrier, to recreate the radicular dentine, to recreate the cementum, to recreate the pulp. Okay, so that is called regenerative endodontic procedure. The simplest one was revitalization. Have you heard of it? You know, you induce a blood clot inside the canal. You go beyond the apex, you induce a blood clot in the canal, that acts as a scaffold and it gives to regeneration. That was the simplest technique. Okay, now we have got, advanced technologies, okay. So we have PRF based regenerative endodontic procedure. What is PRF? Platelet rich fibrin, which they use in all these aesthetic procedures, right? In dermatology they use it. It's like a miracle fluid, right? It's a wonderful scaffold. It can do, actually miracles, okay? It can grow your hair, it can make you much more prettier, all these acne and whatever, it just disappears. So people thought, why not bring it to dentistry? Anything that is working outside in medicine should be brought into dentistry. So we took up the help of PRF, PRP, platelet-rich products, platelet-rich fibrin. So that was used as a scaffold. Now let me tell you, this particular patient, you can see the open apex, right? Now we use PRP in this patient, PRF in this patient. That is platelet. What you see there, that gel-like substance. I'm not going to get into the detail of how you do it because I feel all of you will sleep off. So yeah, you centrifuge the blood, okay? At different speed. There is a speed. I'm not going to get into the details of it. If you are interested, please get back to me. I'll give you my mail ID. I can elaborate on that, or you can go back and read. So that particular jelly-like substance which you see there, that is your PRF. Now can you see how nice and pliable it is? So now you can just take it. He's quite interested because he has done quite a number of procedures in our department. So he is kind of quite excited. I have done this procedure. So this jelly-like substance, yes, you put it inside the canal, okay? So the advantage is this can be mixed with any number of bioactives. The bioceramics or mineral trioxide aggregate, you mix it with it and you can introduce into the canal. So see what has happened. So this was like immediate. This was in 2 months. And this was in 4 months. This amount of root closure and root lengthening should take a minimum of 8 months if you are using a blood clot therapy, but this was just in 4 months. And this is not even a very complicated procedure. You just need a centrifuge. Just need a centrifuge and some technical know-how how to create a PRF, and this is possible. So this is where the research is headed right now, okay? So we have got numerous grants on these kind of products, developing these kind of products, so that for technicians, what I find difficult is, having a centrifuge, taking blood, mixing with bioactives, so all that might be difficult. So what if I give you an injectable system? So a patient comes to you with an immature tooth, you just inject the material and say tata bye to the patient, call the patient after 4 months, you get the root that is formed. So that is exactly what we are working on right now to give you that one-step product. So next, done with our immature tooth, done with a complicated crown fracture. Now we are going to crown root fracture. What is crown root fracture? You have, in addition to your crown, the fracture line also extends into the root. Yeah, anywhere. See, that is what I would like to say. The blood clot therapy will not work if the area is infected. Now, PRF and PRP, they have a lot of immune modulators. They have antimicrobial agents because right now in your bloodstream, right? So it works very well in an infected environment also, where your blood clot will not work. Blood clot will definitely fail if you have an infected environment. Even though repeated disinfection is not going to produce a good result when it comes to blood clot. Whereas PRF and PRP, it works very well even in cases of external root resorption. If at all there is a root resorption, replacement resorption, inflammatory resorption, even in that situation it works. I am not given clinical photographs of that, but yes, we have cases where we have worked on that and it has given good results also. The idea is you can avoid using an intracanal medicament. Whenever there is a replacement resorption, the medication that is given as intracanal medicament is corticosteroid. So there is a lot of questions around using steroid on a growing child on a regular basis because we keep changing the dressing until the replacement resorption gets stopped. So there is a lot of argument, how can you give steroid on a patient, how can you give such strong antibiotics to a child. Now with PRF, no, we don't have to do all that. You only have to disinfect the canal once for 3 weeks and then you can straight away go ahead with PRF. So next we are coming to crown root fracture. As I said, crown root fracture is when you have fracture of crown extending into the root. Now ideally, from now on, I am going to divide all my treatment plan into two things. One for mature teeth, one for immature teeth. What is mature teeth? Yeah, apex is closed. Immature teeth when your apex is open. Because the treatment plan is going to slightly vary for both. Now let's say a crown root fracture. What did I say about pulp? You're going to save it. Even if the pulp is exposed, you're going to save it. You're going to do a pulpotomy. Only and only if you can establish complete non-vitality, you're going to remove the pulp. Whether it is in mature teeth. The previous guideline said that, in mature teeth, if at all there is a crown root fracture, do an RCT. Now no. Even if it's mature, if it's immature, if you could preserve whatever pulp is left, now that's good. Okay? So you are going to do only partial pulpotomy, or let's say even a little bit of pulp is left, use it. Do not go into removing the whole of the pulp. Okay, so there's crown root fracture. You are going to preserve the pulp by using partial pulpotomy or pulpotomy. If you can establish non-vitality, then go ahead with root canal treatment. Now how would I go for a post-dental restoration? Crown root fracture. So basically you want to expose the fracture line, right? Because if it's subgingival, what happens? Can you give a proper crown there in a subgingival fracture? No. It will get exposed and it's going to lead to failure. So you have to expose the fracture line. So you can do it in multiple ways. One is orthodontic extrusion. Orthodontically you pull the tooth out, then you can give a crown. Surgically you can pull the tooth out, you can give a crown, or you can reposition the tooth. Reposition the tooth is intentionally you loosen the tooth a bit and then you reposition so that the fracture line comes labially rather than lingually. Usually the crown root fracture, the fracture line goes lingually. So you are going to rotate and keep the tooth so that the fracture line comes lingually and then you can give a crown. Basically the fracture line should be in an accessible area. That's the idea. So that is for crown root fracture. Now the same crown root fracture in an immature tooth, what are you going to do? Do not attempt for any endodontic procedures. Pulpotomy, wait for re-innovation. Because what is there at the apex? Stem cells. Yes, the miracle stem cells are there. So wait for them to re-innovate. Wait for the vitality to come back. So do not attempt any endodontic procedures if it is an immature tooth. Well, you can, all these crown, all that you can do. You can do a surgical repositioning, you can do an orthodontic repositioning, you can rotate the tooth, all that you can do without an endodontic treatment, right? Root fracture. Now, in root fracture, the earlier guidelines, what is the most unfavorable prognosis of root fracture? Which particular, you divide root fracture into three, right? Apical fracture, coronal fracture and cervical fracture. Apical, middle and cervical. Now which has got the poor prognosis? Apical, middle or cervical? Cervical. Okay, it's got a poor prognosis. But what initial guidelines was, whenever there is a cervical root fracture, extract. But right now, they say that even if it is a cervical root fracture, splendid, do not extract. So we are completely against extraction. Okay, so do not extract even if it is a cervical root fracture. If the cervical fragment is not very mobile, if the mobility is little less, okay, then you can splint it with the adjacent tooth for 4 weeks. They even recommend splinting up to 4 months. Okay, 4 weeks to 4 months. to preserve that small amount of root there. Now, let's say the crown is, the cervical part is completely gone. There is no, you cannot just splint it with the adjacent tooth. It's extremely mobile. Then remove the coronal fragment, retain the root part. Do not attempt to remove the root part. Now, the next question is, what about endodontic